Good afternoon, everyone that has joined us and will be joining us. It's just now noon, so we will start today's webinar. My name is Jennifer Needle Suarez. I'm a faculty member in the Center for Bioethics at the University of Minnesota. We're incredibly pleased to have our two guests with us today and all of you as attendees. I will just go through some brief housekeeping and we will get started with our fantastic talk today. So there will be question and answer function opening. So please put your questions in there. Do not raise your hand, although we've disabled that. We'll be recording this, and all of the recordings from our Ethics Grand Round series are available on our website. We have enabled captioning for the webinar. Please let us know if you have difficulty with that. There will be 3 ways to access an evaluation at the end of today's talk. One, it will pop up in the browser after the talk. We will also present a presentation details document that will have a link to obtaining or to completing the evaluation, and you'll also get an email. If you're here seeking attendance for CEUs, in the presentation details document, there will be the opportunity to request the certificate. For University of Minnesota students to receive IPE credit, you'll complete the reflection form in the presentations details document. Also, biomedical engineering students, there is information about how to obtain your credit for this. And just to note that you should attend 75% of the webinar in order to seek credit. Thank you to all of our co-sponsors. This Grand Round series this year is focused specifically on health equity. And we thank all of our partners for helping us put on this event. The Center for Anti-Racism Research for Health Equity within the School of Public Health, the Medical School of Pharmacy, Center for Global Health and Social Responsibility, Program and Health Disparities Research within the Medical School, the Schools of Dentistry, Nursing, and Public Health, the Rural Health Research Center, and the Community University Healthcare Center. So I'm very pleased today to be able to introduce our speakers. Anne Sosin is a public health practitioner and researcher at Dartmouth College. She has more than 15 years experience leading global health and health equity programs at the international, national, and local levels. And her current research focuses on rural health equity, public health policy, and homelessness in northern New England. Professor Sosin is a lecturer in the Department of Anthropology and Geography at Dartmouth and holds a BA from Dartmouth and an MPH from Johns Hopkins University Bloomberg School of Public Health. We also have Anne Carpenter-Song, who's a medical and psychological anthropologist at Dartmouth College. Her research strives to center the lived experience of rural community members marginalized by poverty, housing insecurity, mental illness, and substance use. Through ethnographic methods, she engages with people and communities to learn about their lived experience with illness, suffering, and experiences navigating the complex landscapes of care. In partnership with people with lived experience, direct service providers, and researchers, she aims to translate insights from close attention to families' lived experiences in rural New England into actionable recommendations for change to improve health and well-being in the region. She holds a BA from Dartmouth College and a PhD from Case Western Reserve University. I'm so pleased to have our speakers today, and we will get started and leave room at the end for questions. Dr. Sosin, feel free to share your slides.
Thank you so much for that introduction and the invitation to join you today. Welcome, everyone. Thanks for coming to our talk. We really look forward to our dialogue together today. Today, we're going to talk briefly about our paper on reimagining rural health equity. Our paper was published in the June 2024 issue of Health Affairs, and we hope that you'll see this talk as an invitation to read the full paper. We have nothing to declare today. I'd like to just give you a brief overview of what we hope to accomplish in our brief time together. First, we'd like to just give you an introduction to our work and to the place where we work. We'd like to provide a little bit of background and framing on the principles that we set forward in our health affairs commentary. We'd like to discuss these principles, and we'd like to think together a little bit about how we might apply these principles in our work. Just to set the stage for our conversation today, I'd like to just talk about how we define rural in our work. About 20% of Americans live in rural communities. There are many definitions of rural. We're not going to walk through them, but want to say that definitions of rural are contested, and these definitions have different implications for policy and practice. We see common economic and social processes that have unfolded across rural America, but we also see significant diversity both across and within rural America. Rural places are dynamic. They're undergoing significant change right now. The COVID-19 pandemic brought into sharp relief the uneven landscape of health in the United States. The U.S. not only reported a devastatingly high toll of death compared with peer nations, but also reported a sharp gradient of loss. Poor outcomes accumulated at the social, economic, and clinical margins of U.S. society. Poor outcomes have also accumulated at the geographic margins. Once seen as a haven from the pandemic, rural communities outpaced urban ones in death beginning in late 2020 and have continued to see a greater death toll. And the impacts of the pandemic have not been borne equally by rural residents. At the peak of the first Omicron wave, Black residents in rural places died at a rate that was 34% higher than white rural residents. Available data also suggests that rural regions will leave with a greater burden of disability from long COVID, but fewer resources to address it. For those of you who have long followed rural health, these COVID disparities come as no surprise. Rural America has seen large and growing disparities for many years, and yet has fewer resources to address these health challenges. Our own work has sought to examine these disparities across rural America and to understand the experiences of rural communities in our own northern New England region. In our work and in the national discourse, we often encounter two schools of thought to explain the source of these disparities. The first is that rural people have made bad choices that have led them to die in much greater numbers. The second school of thought is that rural communities came into the pandemic facing systematic disadvantages that have led them to be exposed, shaped and constrained their choices in adverse ways and put them at greater risk when they did fall ill. Our work, along with other rural scholars, offers a counter-narrative to the broken people discourse, and we hope our talk today deepens your understanding of the ways in which systematic disadvantages have negatively impacted health and well-being in rural America. Deficit narratives around rural America have abounded long before the pandemic, and I'm sure that some of you who, like us, live and work in a rural community encounter these deficit narratives and disparaging depictions of rural places and people. We argue that these narratives have been harmful for many reasons. These stereotypes normalize rural disparities, erode the will to act, and individualize the failure of systems and policies. Deficit-based narratives also obscure significant disparities across and within rural America and ignore strengths amid rural challenges. Drawing both on the academic literature and our research, we instead argue that rural disparities are driven by structural forces and policy choices and not simply individual choices. They reflect the underinvestment in public health and healthcare. They're generated by policies and systems beyond the health sector. They're upheld by narratives that normalize rural disparities, but most importantly, rural disparities are amenable to policy action.
Thank you, Anne. I'll be providing a little bit of grounding now in terms of to familiarize all of you with the research that has informed our thinking. And as we've outlined certain principles to advance rural health equity, we thought it would be useful to just provide an introduction to the work that we've been engaged in, both in terms of research and practice within our rural region here in northern New England for more than 2 decades. And this is work that spans multiple disciplines. And so Anne comes into this space as a public health researcher and practitioner. I come into the space through a background in medical anthropology. And that type of multidisciplinary perspective has been very important for us, both methodologically, but also in really the collaborative work that we're able to do and pushing ourselves into different spaces. And that might be something that we pick up on in the discussion as well. And these particular fields really inform our methods and our ethics of engagement in the work that we do. More specifically, we employ community-based ethnographic and qualitative methods in much of our research. And this is work that is conducted in partnership with community members and with organizations. And these notions of partnership and collaboration really are core guiding principles for us in this space. And we're always thinking about the goal of this work. And the goal is really to think about the gifts of insight that we are granted in the context of deeply embedded community-based work, and then how it is that those can be translated into both relevant actions and recommendations for change within our region. Our more recent areas of research include a range of topics, including work in housing, mental health, and COVID-19. And in this talk, we will be focusing particularly on work that we've done in the context of COVID-19 and housing as illustrative examples from our larger body of research and practice. I'd like to introduce you to the place that Anne and I call home, and to give you a sense of the place that has been the setting of our lives and our work over many years, and to introduce you to this region of northern New England, and in particular, Vermont and New Hampshire. So this has been traditionally and historically a textile mill-based economy. And we have seen shifts economically within this region, as we have seen in other rural regions throughout the United States, notably a transition to a service-based economy, knowledge-based economy, certainly within our region, as we think about Dartmouth College being cited here, a large academic medical center being cited here. And tourism also is a large part of the economy here in northern New England, as we're just in the midst right now of what's termed leaf peeper season. Part of this involves what we think of as contested visions also for rural revitalization. And we see some unintended consequences of these shifts, especially post-COVID. It's also certainly worthwhile to think about our region and other rural regions as being particularly sensitive to the impacts of climate change and other global processes, as within our local region, in particular, the state of Vermont has for the past 2 summers been bearing the brunt of historic flooding events, as we've seen in other regions as well. Northern New England has also faced tremendous housing market pressures. This is something that I'll drill into a little bit in terms of some remarks on some of our research around housing. And just to give you a sense of kind of the governance structure within this region, we are organized in small towns and villages. So most of our towns are around 3,000 to 4,000 residents. Governance is hyper-local. We have virtually no county government within the region. And there's a very strong tradition of local action and civic engagement. Interestingly, our region in the Northeast is perceived as quite politically progressive, but when you look closer and kind of on the ground, you see, in fact, that it's much more purple than that. There are very strong libertarian roots in New Hampshire. There's also a strong, what we have described in other work, there's a strong rural ethos, this idea of neighbor helping neighbor, a strong sense of pragmatism and an orientation to action. However, there's a shadow side to that as well. And once you fall outside of that norm, you are perceived to not be taking responsibility for yourself, one can fall outside of those social norms. This is a context in which work is very much valorized. To introduce you just briefly to the healthcare landscape within our region, this is a network that includes large academic medical centers, coupled with a network of critical access hospitals, community hospitals, FQHCs, and community health centers. And these various types of settings really form the backbone of care in rural regions, particularly our smaller institutions, which often serve as anchoring institutions, both for the health and well-being of communities, but also performing other functions as well. And just a brief note, and I know this was something that was brought up in some of the previous questions, just to note that critical access hospitals, this is a federal designation, and these are settings in which they're reimbursed at a higher rate by Medicare at 101%. And this is in recognition of the role of these types of small hospitals really being a safety net for rural communities. We've also seen within this context, as in other rural healthcare settings, significant financial pressure. We have seen health workforce shortages, concerns about viability of our rural health settings, huge capacity challenges and strains, and also the consolidation of care as large hospital systems have expanded throughout the region. And so as we think about the region of Northern New England, as we think about kind of top line indicators, Northern New England typically performs much better on many health indicators than other parts of the United States. And yet a closer examination reveals disparities both across and within communities within this region. So I'd like to highlight some of the work that we have done, and in particular to underscore the methods that we have employed in our work. And again, these are just two examples from a broader body of work that really have informed the principles that we set forth to advance rural health equity. And so in March of 2020, Anne and I embarked on rapid research to understand the experience of the COVID-19 pandemic in rural Northern New England. And this was work, like so many of us, we were at home and we were thinking together about the skills that we could bring into the space of addressing issues relevant to the unfolding pandemic, thinking what's our unique purchase within this place? How can we be helpful at this moment? And so we, over Zoom, from our respective houses in New Hampshire and Vermont, we interviewed more than 80 key informants representing people from multiple sectors, the health sector, education sectors, town and local government. We really wanted to catch a wide net of experience to understand the impact of the unfolding pandemic on health systems and also on our rural communities. And through this work, we identified key gaps in the pandemic response, as well as hidden strengths and creative responses within our rural health systems and communities. Another key area of work that we have been engaged in is around homelessness and housing insecurity in rural New England. And this is work that I've been engaged in for quite a long time, beginning in 2009. And I've used methods of longitudinal ethnography over more than a decade to trace families' experiences of homelessness and housing insecurity in Vermont and New Hampshire. I've also had the opportunity to engage with clinicians and social service providers and organizational leaders to understand their perspectives and practices around how to best provide care to marginalized community members. And some of the things that come to the fore through this research is really that homelessness in rural areas is much more hidden compared to the visibility of homelessness in urban settings. We see that families are often doubling up, staying in pay-by-the-week motels, camping, sleeping in cars, or staying in shelters. And some of the things that I wanted to note in terms of what's driving the problem of homelessness within our region, we see that in our region, this reflects many common factors that are driving homelessness nationally: a limited housing inventory, the scarcity of affordable housing, lower wage service sector jobs that don't pay enough for market rate rents. And yet, when we also look closely, we can see that there are specific challenges within our region, including the high cost of living despite being a rural area. Northern New England in particular is a region that attracts highly educated and skilled workers to the region, which often has the unintended consequence of driving up housing costs. This is a situation that really has worsened since the pandemic as remote work opportunities expanded. At the same time, there are limited opportunities for those without high levels of education or advanced training in the trades. This is also can be a challenging physical area to develop, including workforce shortages, a lack of infrastructure for larger scale housing developments or congregate apartment buildings. And this is also shaped by policy choices, including around conservation. There are also factors that involve how we collectively imagine rural spaces as well, that shape practices and responses to homelessness within this setting. Researchers working in the United Kingdom have identified what they call a conceptual non-coupling of rurality and homelessness, by which they mean that the idea of homelessness is incompatible with an idyllic vision of rural spaces. And I would add to that, within the US, I argue that this is amplified by assumptions that housing is accessible and cheap within rural regions. We also see that within the region, by looking closely, we can see very hyper-local microgeographies of privilege and poverty that are producing forms of social exclusion. So through this work, and these are examples of the trajectories of 5 families who I followed for many years, most research on homelessness focuses on periods of time when individuals and families are unhoused or are living in shelter. By contrast, the methods that I employed enabled me to bear witness to families' experiences during times of relative stability, as well as times of relative precarity with respect to housing. And this longitudinal perspective thus provides us with insight into what are the factors that contribute to families' well-being? What are the factors that erode family stability over time? And a key finding from this work, as illustrated through these visuals, is that most families endured chronic housing insecurity and high mobility over the course of this time. Homelessness itself may be episodic, but housing insecurity was chronic. Taking the long view revealed continued vulnerability to losing housing amid structural constraints, the lack of affordable housing, and lower wage work, which reflect policy choices that have limited development of housing amid shifting dynamics and growth within our rural region. So these types of research experiences that we have had over the years, the type of work that we've been doing has really informed, and Anne's going to run through some of the persistent myths that we have become aware of that adversely affect rural health equity.
So across our work, we hear many of these myths persist over time. One myth that we heard, especially at the beginning of the pandemic, was that rural places were immune to COVID-19. We also hear that they're immune to other challenges like homelessness. We hear a lot that rural places are all the same. rural people are all the same, and that myth persists in the media and public discourse. We hear it a lot in our own work, and much of the scholarship that we look at disrupts this myth in many critical ways. We hear that small populations do not matter, that maybe rural health equity work isn't even health equity work to start. And we hear about the deficits of rural places or institutions. Sometimes we even hear that these institutions don't exist. And our work in many ways responds to these myths and to some of the gaps that we see in the thinking around rural health and rural health equity. So I want to introduce you to the principles that we have set forth. These are intended to be broad guiding principles to inform research, policy, and practice in rural America. I'm going to give you a very brief introduction, and then we hope that we can discuss some of the principles and how they might be applied in greater detail. The first principle that we set forward is that rural health equity is equity. Rural health equity efforts in rural places have grown in recent years. However, the concept of rural health equity remains inconsistently defined. We see that some researchers and practitioners see rural health equity as primarily centered on the differences between rural places, whereas others center on one or more groups experiencing disparities in rural places. And poverty and demographic differences are often given as factors to explain rural health disparities. Yet, as I will explain shortly, the COVID-19 pandemic revealed the need to move beyond a conceptualization of rural health equity that's grounded simply in geography, poverty, or demography, or focused more narrowly on groups that are within rural places. Just as a foundation for our conversation in this first principle, I want to lay out two definitions that we commonly employ when we are thinking about health equity. And I know that many of you use different definitions in your own work. The first definition comes from the Robert Wood Johnson Foundation. And the Robert Wood Johnson Foundation defines health equity as fair and just opportunity to health and encompasses a broad range of factors, including poverty, discrimination, and the social and economic determinants of health. The second that we use comes from a 2006 World Health Organization paper and distinguishes inequities in health as from differences in health as those that are systemic, socially produced, and therefore modifiable and unfair. And I'd like to just use the example of COVID-19 to talk about why we see a need for a more expansive definition of rural health equity. When most of us think about risk to COVID-19 and other health threats, we think about underlying health status at the individual or population level or the healthcare system. And we all know that people with underlying health conditions are at greater risk of COVID-19, and that vaccination and other biomedical interventions can reduce this risk. We also know that access to healthcare shapes health outcomes, and rural places have lost hospitals, pharmacies, and primary care providers. But vulnerability to COVID and as well as other threats also reflects exposure and transmission patterns. And these exposure and transmission patterns are largely shaped by social factors, including occupation, living conditions, and transportation. And while rural regions have lower population density and geographic isolation, other features of their economies structure risk of exposure and transmission. Prisons, meat packing plants, manufacturing facilities, and extractive industries concentrate in rural regions, often in towns with larger shares of Black and Hispanic residents. And these epidemic engines have not only been the sites of large and deadly outbreaks, but have also driven growth of COVID-19 within communities. Our northern New England region also relies on common commercial centers and anchor institutions that draw together a highly mobile essential workforce from a large geographic area. And these rural disparities, we argue, reflect disproportionate risks and exposure and adverse outcome at both individual and population level. Drawing on this analysis, we propose defining rurality as a distinct dimension of health equity that's centered on addressing rural disadvantage. And we use the term rural disadvantage to describe how health in rural settings is structured by forces that include, but also go beyond geography. Rural disadvantage, we argue, reflects the interaction of global and local historic, economic, environmental, social, policy, and institutional arrangements that adversely shape the dynamics of health in rural regions. Rural disadvantage also intersects with other dimensions of equity, including structural racism, ableism, and gender-based discrimination to generate health disparities. And in our paper, we take we highlight the interaction of rural disadvantage and ableism. We know that rural people have a higher prevalence of disabilities, reflecting increased occupational exposures and more limited access to rehabilitation care. We also see that rural people with disabilities encounter less accessible built environments, more limited access to specialized care, and stigma related to disability. And we also share this new piece that came out in NPR just yesterday that really highlights the interaction of structural racism and rural disadvantage. The second principle highlights the need to center rural disadvantage in policy and practice. Building on the first principle, we argue that advancing rural equity requires explicitly and systematically addressing rural disadvantage. When we see that while many policy statements mention rurality in rural communities, we argue that much more explicit attention is needed to rural disadvantage. Our own research has highlighted the many ways that inattention to rural disadvantage can generate inequities. And we share some examples from our own research. A state vaccination campaign employed a single mass vaccination site for large rural areas. And using a one-size-fits-all approach designed for urban centers with high population density ignored the geographic and social barriers faced by many rural residents in accessing a centralized site far from home communities. And rural public health leaders with whom we spoke reported that absent local efforts to establish pop-up sites, many rural residents would have encountered up to a 4-hour trip for a single vaccine dose. Rural healthcare delivery was also subject to stress during the pandemic. We saw that critical access hospitals that were unable to transfer patients for care, absent mechanisms for the allocation of critical care. We also heard many accounts from rural health school leaders of the ways that inadequate technical, financial, and political support for rural schools to implement COVID mitigation strategy hampered their ability to respond to challenges during the pandemic. Each of these examples reveals missed opportunities, we argue, to mitigate rural health equity through explicit attention to rural disadvantage. But these examples also highlight that rural barriers are amenable to intervention. And these examples highlight that actions to support or impede rural health equity are embedded not only in structures and policies, but also within the everyday practice and decision of stakeholders at the federal, state, regional, organizational, and local level. And we see this as an invitation to all of us to systematically ask how existing policies and practices may impede or facilitate rural health equity, and see this as something that we all can do in our own work. The third principle that we set forward is that there's a need to address rural disadvantage across the lifespan. Rural policy conversations often center on the challenges confronting older populations, and rural populations are indeed on average older and often in poorer health compared to urban populations. Yet we want to suggest that a narrow focus on aging demographics and older populations obscures both large and growing health disparities across the lifespan, as well as opportunities for an intervention across the lifespan. Seeing that rural children have not seen the same improvements in pediatric mortality as urban children, and rural disparities have been found to be greatest among Black and Indigenous challenges. And these disparities persist into midlife, with rural adults lagging behind their urban counterparts. Moreover, COVID-19 highlighted the role of younger people in shaping population health outcomes and the secondary consequences that policies designed for older populations may have on young people. Younger populations also face greater health risks in workplaces and shape the transmission of infectious diseases at the community level. Fully realizing rural health equity, we argue, will require creating conditions for thriving across the lifespan. And we advocate for attention to rural disadvantage across the lifespan in setting rural health equity agendas, crafting policy, and in designing programs. And as an immediate priority, increased focus on narrowing rural gaps in access to healthcare and evidence-based practice, including mental health and substance use treatment for younger populations, is needed. We also suggest that addressing rural disadvantage across the lifespan will require interventions across many sectors, including education, labor, criminal justice, and public safety.
And our fourth principle really gets at what are some of the key methods and approaches that can be used to address rural disadvantage. There's been significant attention, as many of us are aware, to what we might think of as rural resistance to public health measures. And many of you in some of the pre-work questions have asked about what we can do collectively to address such challenges. And we see opportunities really to move beyond such damaging surface level depictions of rural places and people. And we advocate specifically for the application of methods that really allow for deep inquiry into rural experiences of health, healthcare, and public health. We argue that top-line indicators often conceal the more subtle dimensions of experience and of groups experiencing disparities. And so in particular, we call out some of the ways in which qualitative and community-based methods are particularly useful, and especially for being able to elevate and center the experiences of small, marginalized, hidden populations living within rural communities. Qualitative methods are also very useful for identifying factors that can facilitate or enable more effective responses. And partly this is through the modes of inquiry that allow us insights into the lived experiences and the local perceptions of health challenges, of illness experiences, how people are engaging and thinking about mental health and public health measures and clinical care. These types of methods are also very well suited for identifying what are often the hidden strengths, the creative responses, and this is something that we call for. How can we have greater attention to rural strengths and assets within communities? Qualitative methods are also helpful for helping to bring into focus the unintended consequences of policy action and of practice, as well as strategies to adapt interventions to rural contexts. As we think about these methods, we note that robust, community-based qualitative methods require specialized skills, and in particular, investments of time in order to build trusting relationships with community members, and also an ethical stance of authentic partnership to center the concerns and priorities of local residents. And in the two examples from our research, you can see that this can exist along different temporal horizons. Our COVID work was conducted very rapidly. Immediately in March, we were thinking about what we could do and rolled out a series of interviews. And along the way, we were conducting very, very rapid analysis and disseminating that out to various community groups, policy audiences, writing policy briefs. In the second example from the housing work, you can see a very long temporal horizon. And so we advocate for awareness and thinking about what types of methods would be best suited to the research questions that you have and the goals that you have for your work. We call in particular on funders to invest in rural research that employs a broad range of methods, including this type of deeply embedded, community-based and action-oriented research, as well as capacity building initiatives for policymakers, public health practitioners, and health professionals in the rigorous application of these methods. And really, this call for rigor is something that I'm sure many of us on the call share a concern with the potential harmful legacies of extractive traditions of research and the types of institutional harms that can often come into play in the context of research with marginalized populations. And so this is something that we continue to strive for, an ethic of partnership in our work. This is something we call on others as well, and a continued awareness of the complex power dynamics that are at play in the context of this work. Our first four principles call for a deeper understanding and attention to rural disadvantage. Our fifth and final principle calls for actors to build on rural assets and strengths. And although full accounting of rural challenges and the forces that led to them is certainly necessary, this should not come at the expense of rigorous analysis of the strengths, assets, and opportunities that exist amid these types of challenges. In particular, we note that a narrow focus on deficits can obscure local strengths, can undermine rural leaders and institutions, and erode the political will to invest in research. Our work, as well as the work of other rural scholars, consistently finds these types of hidden strengths and creative, effective responses amid challenges. Again, as many of you are thinking about what it is that you can do to promote rural equity, we highlight in particular the need to preserve institutions, to equip rural leaders and institutions with the political, the material, financial, and technical support that is needed. And this includes investing in the next generation of rural practitioners and leaders and thinking creatively about how we can sustain and nurture our rural workforce. As we look to our own future research, we are placing these types of questions at the center of our current inquiry.
So I'd like to talk just very briefly about how we might apply these 5 principles to an emergent public health concern, the H5N1 outbreak in the U.S. And let me just touch on this really quickly, and we could examine other examples together, but I'll pull this one because it's in the news, and I know that so many of you are thinking about it right now. When we look to the unfolding outbreak, we see that which is primarily taking place in the agricultural industry. We see that the agricultural industry is concentrated in rural America. This is a rural public health challenge. Often this is not named as a rural health challenge, but we see that the agricultural industry relies heavily on a highly precarious young migrant workforce. And so we see the intersection of both rural disadvantage as well as with other dimensions of health equity. When we look to these places, we know that there is a mismatch between the challenge and the infrastructure that's in place. Right now, we see that the outbreak is concentrated in many states that have lost hospitals, and public health infrastructure. And when we think about how we might respond to the outbreak, we also see that there's an opportunity to employ broader set of methods to understand some of the public health and delivery challenges that are emerging in the response, and including the resistance that we're hearing about to some of the public health challenges. Let me stop there. We'd like to thank you for joining us for this introduction to the principles. We really look forward to engaging in further dialogue with you, hearing your questions, and thinking together about how we might apply some of these principles to advance rural health equity. So thank you again.
Thank you all so much. That was really incredible and resonated so much in a lot of the equity work, more urban equity work that people at the University of Minnesota are doing, but also elsewhere. And it leads me to my first question, which was also brought up by someone in the audience, is when we seek to define the rural population as a homogeneous entity, then we assume that the rural healthcare needs in northern New England are the same as in Southern California. And I'm just curious if you could address a little bit how local rural disparities may play into this, and thinking about policy on the local, state, federal level, and where it may be most effective.
And would you like to start with that?
Sure. So let me perhaps start with the first part of the question. So we see two tendencies. One is to essentialize rural, to think all rural is the same. The second is to think that rural places are so unique that it's impossible to characterize or to see common processes across. And so we need to hold these two things. And we suggest that there are common processes that have played out across rural America that have adversely affected many rural communities in similar ways. But at the same time, there's significant diversity both across and within rural America. And we see that in our northern New England context as well. As Elizabeth mentioned, we boast the best health indicators in the country, but then once we drill down beyond those top line indicators, we see very significant disparities at county and at local level. And some of those top line indicators can obscure the disparities that some groups within the region are experiencing. And so it's not either or. In terms of thinking about rural health equity, it's recognizing that global, national, regional forces interact with very specific local dynamics to generate uneven conditions for health and in rural America. So Elizabeth, maybe you can take the second part of that question.
Sure, and just thinking about as well, kind of the methods that we advocate, I would say really enable insight into those kind of multiple levels that are impacting. So oftentimes in our work, we're really centering lived experience and starting there, the first person perspectives and lived experiences of rural residents and rural practitioners and leaders. But within those narratives, you absolutely can see the impact of what's happening locally, regionally, and nationally. And so this is something that I think by tacking between these different levels of analysis, that's really important for us to bring into focus kind of what are the potential opportunities for intervention at those various levels.
And if I can expand just a little bit on that and thinking about policy and translating research into policy, one of the things that we advocate for a lot is attention to specificity, both in terms of what's generating health disparities as well as in advocacy priorities. And these methods can inform that type of specificity, but we really say we need to focus on where are the opportunities specifically, and how can we bring our research or our collective work to bear on those priorities.
Great. Well, transitioning to research, there are a number of questions. And I'll just leave it sort of open-ended, pull them together and let you answer it however you choose. One, I think you addressed in many ways talking about the way you do your community-based work, but one question is about engendering trust from rural communities in research. Also how we help encourage rural residents to participate in, academic university research projects. And then a third part of that question would be about funding and how we help funders understand the priority of rural health equity.
Thanks, Jennifer. I can jump in to begin, and Anne, please add. The question of trust is paramount, and this is deeply, as so many of you on the call are well aware, this is deeply relational work, and this involves really being embedded within communities, often over long periods of time, and taking the time to develop relationships and understanding first and foremost. One of the reasons why we call for the continued awareness and reflexive kind of thoughts about the power dynamics is thinking about what it is that we bring into the space. And Anne and I are well aware that we sit at a large academic institution, and sometimes there is quite a bit of repair work that has to be done as we are engaging with community members, as we are engaging with other rural institutions. And that's something that we have to earn that trust over time. This is something that we can have a commitment to this, but that's something that has to be embodied by our continued presence, by being willing to show up, keep showing up, and through the type of work that hopefully people can see us, really trying to do our best to translate the work out and to write and to speak with different audiences and to work with and collaborate with a wide range of actors in order to actually hopefully translate this work into meaningful change. So I think that's first and foremost is the deep investment in relational work. The involvement of rural residents, this is something that is so exciting. And there's so many opportunities to think about ways not only beyond engagement as research participants, but over the years, I've certainly tremendously benefited from having community members with lived experience of housing challenges, of mental health challenges, serve on advisory boards as parts of projects, and have informed the research priorities over time as well. And so I think that's such an opportunity, and there's obviously a long tradition of research with community-based participatory methods that really elevate those types of approaches. And we would absolutely advocate for thinking about whether or not some of those strategies could be applied in the research that some of our audience members might be thinking about. And then finally, to the funding point, this is something that we make a call in the paper for the type of investment in these types of methods. I think unfortunately this does seem to be a continued area of underinvestment, and so we would hope to see greater attention to these issues and an expansion of funding opportunities over time.
Thank you. You talked somewhat about closure of rural hospitals and the impact of emergency medical access for the rural communities. Within the community, I'm curious in your work if that rises to the level of concern more, less, or the same as lack of access to basic preventive care.
I would say that this issue is front and center for our region right now. Both states, are engaged in active discussion around the consolidation of care in our region. There are proposals on the table to close several hospitals, and so many are thinking about this and the impact that closure of facilities or conversion of facilities will have not only on access to healthcare, but on economic vitality in the region. That said, in our region, I don't hear it as hospitals versus primary care, but rather this concern about the constriction of access to any type of care. We're losing or we're at risk of losing hospitals, but also there are significant challenges around primary care, access to pharmacies. When we lost pharmacies when some were hit by flooding over the summer. So these issues are front and center in our region, and I know they are in many parts of rural America as well.
I would like to close to ask your opinions as far as we are in a season of discussing policy. Where you think the trajectory of the public health response to this issue is, in the sense of, are we making inroads? Is it getting worse? Are there recent policy enactments that have made small inroads? Just curious where you feel like we are on the trajectory of appreciating this mechanism for health inequities.
So maybe I can start, and then Elizabeth, you can chime in. So I guess I'd have 3 points in response to that question, and I hope I'm answering it directly enough. But the first thing I would say is that health challenges in rural America transcend political party or ideology, and there's a real opportunity to build across the political divide as we think about rural health, and we shouldn't lose sight of that. The second thing I would say is that we have an opportunity, right now, to preserve the rural health landscape. These are policy choices that we can all influence. And so I'd move us back a little bit from the very polarized political environment to think about this is a space that's rich in opportunity at this particular moment. The third thing I'd say, just thinking about the political health nexus, is that there's an opportunity for us to really engage in what some scholars have described as deep listening, stepping back from the political fray and really taking the time, using some of the methods that we have described to understand the challenges, the fears, the frustrations, the concerns of people living in rural America, and to build a way forward beyond some of the divides that we see right now. So Elizabeth, what would you add?
Yeah, only to add really that I think, again, the types of methods that we advocate for are really an opportunity to humanize experiences within rural America. And this can offer, I think, a very useful, very powerful counter narrative to what we see oftentimes as quite damaging surface level depictions of rural America. And I think those are amplified right now in the context of our political polarization. So again, a call for, I love that, and the call for deep listening, the call for deep engagement would be something that we would hope folks on the call come away from today.
Well, I know there were a lot of questions that did not get answered. I'm certain our speakers would be willing to field them by email. I shouldn't volunteer you, but I really want to thank you so much for this talk. I think it really highlighted an under-addressed issue in health equity. We're so pleased to have you and your work. And I just wanted to announce next month's Ethics Grand Rounds will be with our own Mary Owen, discussing end-of-life choices with American Indian and Alaska Native patients. And also on December 3rd, our other lecture series, which is called Unpacking Bedside Bioethics, will be presented by Trevor Bibler, who wrote a fantastic paper about how to address the miracle concept with parents of children who are in the hospital. And so he'll be presenting, Do You Believe in Miracles? Productively Engaging Hopes for a Miracle. And then for those of you that are local, just wanted to highlight 3 courses that the Center for Bioethics will be teaching next semester. And please reach out to us if anyone has any questions or interest. And thank you all to the audience for joining us. Again, thank you to our speakers for a really engaging, thoughtful discussion, and we really appreciate your participating with us today.
Thank you so much for having us.